Today's episode is brought to you by Microsoft, who is committed to helping physicians reclaim their work-life balance and restore the joy of practicing medicine. Discover DAX Copilot, your AI assistant, for automated clinical documentation and workflows. To learn more about how DAX Copilot can help improve healthcare experiences for both you and your patients, visit aka.ms/knock-knock-hi. Again, that's aka.ms, like Microsoft, /knock-knock-hi.
Knock, knock. Hi.
Hello, everybody. Welcome to Knock Knock Eye with Dr. Glockenflecken. That's me, your host, your one-stop shop for all things eyeballs. Are you excited? You ready? I'm ready. It's a good day. It's Friday. It's the weekend. I still get so excited. Although as I've gotten older, when I was like in college and in med school, like Friday night was like the party night. I was like, you go out, you have fun with your friends, you drink, you do whatever you want. Now as a almost 40-year-old, Friday night is like the night that you crash early because you're so exhausted from the week. And then like Saturday night's the good night on the weekend for me now, because you still have a whole day on Sunday that you don't have to work, but you have a little bit more energy because you didn't work all day Saturday. And so it's like Saturday night's the fun night. And by fun, I mean like watching a movie with the family. That's as crazy as it gets around here. It's and it's lovely, wonderful, especially this time of year. It's Christmas time as of this recording, and so we're watching The Grinch, both the better animated version and the horrible Jim Carrey version. My kids love both of them for some reason equally. All the Christmas movies going on in this house, and I'm fine with it. Once a year, it's okay. There's a great one on Netflix, Klaus. I guess you say Klaus, Klaus. Awesome, love it. We watch it every year. It came out like 3 years ago. Kids love that one. They also love the Polar Express, the creepy one with Tom Hanks. It's like Uncanny Valley, weird characters. The kids, they're just a little bit not quite human-like, but just human enough to be unsettling. Anyway, they like that one too. So those are probably the most played. And Home Alone, of course. Home Alone, classic. So anyway, but this is an exciting weekend because our final live show of 2024 of Life and Death with the Glockenfleckens. It's our 12th or 13th show of the fall, and I'm sad that we're not going to have a show for a while, but we have more coming in 2025. It's just been so much fun, and we're ending on a high note because we're going to Chicago, my favorite city. Love it. I love Chicago. I spent my intern year in Chicago. We're going to be at the Improv there, and it's in Schaumburg, which I've been to a few times, kind of outside. It's in the burbs of Chicago, but they have an Improv, and it's going to be great. I'm excited. I'm going to see some friends, some people I met through social media, actually. I'm going to see a friend that I used to write on Gomer Blog with. Any of you remember Gomer Blog? Shout out Gomer Blog. The first, I would say, I like to say the first Onion impersonator out there. Like we were trying so hard to be the Onion for medical people. Had some good moments. Eventually, it kind of crashed and died, and Glockenflecken came out of it. But I wonderful friends from my Gomer Blog years. I probably wrote like 100 articles for Gomer Blog. There's a lot of stuff out there. It's probably all archived at this point, so you could probably find it. I was publishing under Dr. Glockenflecken, by the way. So, but anyway, Chicago is, as I mentioned, it was the site of my intern year. And let me just tell you, I've been reflecting on my intern year a bit over the past few days and getting ready for this show and what I'm going to say, because I'm going to talk about this. So back when I did my intern, back in my day, this was 2013. I graduated in the spring of 2013, and then started my intern year that summer. And so I did it at a place called Resurrection Medical Center. It's a little bit outside downtown to the west, like the northwest suburbs. Resurrection Medical Center. And it was so rigorous, this transitional year program, that we called it Club Res. Just to give you a sense for just how hard we worked. It felt like stealing money from the government, getting paid to do this job, because there's a reason that it's things are different now, because now all the ophthalmology programs have it's a combined internship. Like you generally can't do like a separate intern year and then you go to a different place to do your residency. But that's what it was like for me. So I applied for my residency programs, and then I applied separately for my intern year programs. And I was targeting transitional years, because that's kind of what you did. If you had a strong application, which I did, I was like, "Ooh, I'm going to get a good transitional year where I don't have to work." And I'm exaggerating, but the idea is like in these transitional years, you're not doing any ophthalmology. And that was what it was like. Like none of the intern years had a significant ophthalmology opportunities out there. And so in my mind, I was like, well, what the hell am I going to spend? Why do I want to spend 8 months doing general surgery or internal medicine? Like, that's really not going to help me. So I might as well make it as easy on myself as possible. So I applied to all the best. I went on, Student Doctor Network, and I looked for all the easiest, the ones with the cushiest reputation. And I found a list. I applied to all of them, and I really only got like 2 interviews out of like probably 20 programs that I applied. I got a lot. I got more interviews than that, but the ones that were the best ones out there, I got like 2 of them. And Resurrection Medical Center is one of them, and it was like top of the list for me. And I got there. I had my interview with the transitional year program director. And during the interview, I found out, because I was coming from Dartmouth, I found out that he was a Dartmouth undergrad. He graduated from Dartmouth. And I walked out of there, I was like, I'm coming to Resurrection Medical Center for intern year, and I am going to work very few hours. It's going to be fantastic. And that's what happened for part of the year. We did have these month-long electives. I got to do 2 months of radiology, 2 months of radiology elective. And this was it was in the hospital, but it was a private radiology group. There's a big difference between private practice and academia, especially in things like radiology, because those radiologists in that private group at that hospital, they could not care less about our presence in the reading room and teaching us. They were just trying to work as hard as they could for 8 hours and then go home and get the hell out of there. And so all of us, for those rotations, we signed a piece of paper, we got a little textbook, and we left for a month. I don't know if I should be saying this. You know what? It's been 10 years. I think it's fine. It's changed now. It's no longer like this, by the way. All right, this is, and I think it was us. I think we ruined it. But my favorite story from my intern year was actually on one of the 2 actually difficult rotations that we had to do. So one was emergency medicine. The other one was ICU. And this was as legit of an ICU rotation as it gets out there among any residency, because it was a community hospital. There was a MICU, a medical ICU, and a surgical ICU. And when you were on nights, you covered both alone, by yourself, as an intern. We're talking like 12 on each unit. A lot of patients. Just us. That was the rotation I started my intern year on. I was a brand new intern, and within like the first 2 weeks, I was doing nights. I did like 3 consecutive nights in the ICU by myself. When I say by myself, I mean like physically, I was the only physician on the unit. There was a fellow or an attending that I could reach by phone for any admission. I'm going to tell you right now, this was not safe. Like this is not the way to do medicine for trainees. Like looking back on it, I honestly cannot believe it. I was pretty smart, but I was not like ICU smart. Like I did not focus on any of that in medical school. So it was a struggle. It was terrifying. And then also this community ICU, in addition to having a fellow or attending by phone who was like at home. How helpful is that when shit's going down in the ICU? There was, when you'd go into a room, there would be they had this like video monitoring system. I don't even know what this is, but you'd walk in and then occasionally you like hear the voice of God in the room be like, "What's the blood pressure? What's the drip at? Could you calculate Winter's formula?" I don't know. They say things to me, and I just like, what's going? Who are you? God? And they were there to help apparently. And so like those nights, oh man. I mean, we're talking 2 weeks into being a doctor. I'm just surviving. That's my goal. I'm surviving, and I'm trying to make sure like people don't die. That's all I'm trying. If I get out of here, nobody dies. Success. But there was one patient on the nights, and generally it went okay. Everything went okay. I survived, and the patient survived. But there was one night when a patient did come in very, very sick. I don't even remember exactly what it was. I do remember, though, calling in the middle of the night, calling the attending, because I had to call them for every admission. Be like, this patient, here's what's going on, blah, blah, blah. I can't even use the words now. I'm an ophthalmologist. I don't know. And I just remember the attending saying, "Okay, we need to start ECMO protocol." And I steeled myself, took a deep breath. I said, "Yes, sir. Of course. I will start ECMO protocol." I hung up the phone. I walked into the physician workroom, sat down at a computer, and Googled, what is ECMO? That's what I was working with. And I relied on everybody else around me to help me get it done. That was the lesson for me. It was like, oh, this is super multidisciplinary, this ICU medicine stuff, especially as an intern, but probably even as an attending. It's like the nurses kind of knew what to do. They're doing all their stuff. The pharmacist, I was on the phone with the pharmacist. I think I got a fellow in there eventually, but man, harrowing experience. And it's fun looking back on it now. Like I can laugh about it. In the moment, I was like, how does anybody allow this to happen? But they did. So, I apologize to anybody in the Chicago area who may have been a patient at Resurrection Medical Center around this time, who had a gangly, tall, very probably a timid appearing doctor named Flannery. I did my best. Let's take a break. I have a slight different type of topic that I want to talk about today. This was something that was recommended to me by somebody on the Glockenflecken team. Shout out Lori, who does a lot of great work for us. And she was like, here's what I want to know about. Tell me about bionic eyes. which is a great topic because that's something that comes up on social media every now and then. The idea of a bionic eye. We've talked about implants, cataract surgery implants. There's also glaucoma implants. There's tubes. There's shunts. There's other devices you can use during surgery. There's things you can put in the eye. We haven't talked about bionic eyes. And I actually had to do a little bit of my own research onto this. I heard some of this stuff because it's all very experimental. It's very rudimentary in some ways, but also if you look at it a different way, it's extremely advanced. And it's fascinating and amazing that we can do some of the things we can do. So I'll just tell you what's out there right now. What are we doing in the bionic eye space? So first, how about what is exactly a bionic eye? So to me, the term bionic eye refers to something that you're using where the goal is to replace the natural eyeball or the natural eye function. All right. So we're not talking about like an implant for cataract surgery. That's just a lens. No, we're talking about the eye. You're trying to replace the function of an eyeball. And this technology has been around in some form or another. I learned this. This is really cool. Back in the 1700s. How about this? A precursor. We're calling it a precursor to the bionic eye. 1755, Charles Leroy, a French physician. So he used a Leyden jar, which I had to look it up. A Leyden jar is a thing that stores high voltage electric charge from an external source. So it's just this thing that holds an electric charge. So using this Leyden jar, this doctor discharged static electricity from the jar into the body of a blind individual using two different wires, probably right on the temples of this person's head. The person said he experienced a flicker of visual perception as a result. Cool, right? 1755. So you can electrocute. I wonder if anybody who's ever been struck by lightning, who's blind, what do they see? That'd be interesting to know. That'd be probably a very rare thing. Not only do you have to be blind, but you also have to be struck by lightning. Probably not a lot of people out there that qualify those two conditions. But in modern times, the bionic eye has been, in some form or fashion, has been present since about 2012. So we're about a little more than 10 years into the bionic eye era. So unlike a prosthetic eye, a bionic eye is functional, right? It's not cosmetic. So when someone develops blindness, all right, they cannot see because of a variety of different factors. Diseases like damage to the lens, a bad cataract, cornea, somewhere you've lost the ability to have light come into the eye, or the retina being unable to perceive light. These are all things that cause blindness or damage to the optic nerve. Any of these critical structures of the eye can lead to blindness. In the US, the bionic eye that's currently in development, that's had the most development, is what's called the Argus II Retinal Prosthesis system. The Argus II. I've heard about Argus really since med school. And right now, its primary focus is being tested to restore sight for people with age-related macular degeneration. And as well as that, some other inherited retinal diseases like severe retinitis pigmentosa. So macular degeneration in its severe form, it causes just you lose photoreceptors. You lose your light-sensing cells. And then in retinitis pigmentosa, same thing. You lose your photoreceptors. All right, so the bionic eye, the goal is to give the patient the ability to send an electrical signal, a visual signal, to the brain somehow. And so the way this Argus II system works is it consists of a pair of glasses, And on the glasses is a small camera. And then there's also tiny electrodes. So the camera's on the glasses. The electrodes are surgically implanted into the retina in the back of the eye. So here's how it works. When a person looks at something, it triggers the camera to take a photo, and it converts that photo into a signal that's sent wirelessly to the electrode implant, the implant that contains all these electrodes into the retina. The retinal cells are stimulated by the electrodes, and then its information is then sent from the stimulated retinal cells to the optic nerve. And so this can work in certain diseases where you don't have photoreceptors because you're kind of bypassing the photoreceptors. The camera is sending the signal, and that signal is being directed to the other cells in the retina that then propagate the signal through the optic nerve to the brain. Super cool. Super cool. Now, the one downside right now is that this system, this Argus system, it only like max of like 60 electrodes, 60 electrodes, and that is not nearly enough electrical signal to give you a normal visual image. So patients that have had this, and it's been successful for a fair number of patients, there's some, small numbers, but what patients have been able to see, and for years now with this system, is basically images like high contrast. So they could see like objects, large objects, high contrast, light and dark, basically enough to be able to see some movement, to be able to see light coming from different directions, shapes, rudimentary vision, but better than no light perception, which is what these patients who had this device placed were able to see, was nothing. And all of a sudden they can see these things enough to navigate, to know, oh, I should avoid, there's something in my way, I need to go around this. Or I can see where the light's coming from the hall. Let me go walk that way. That's amazing. That's incredible. And just to give you a frame of reference, in order to have a normal vision image, you would need roughly 1 million electrodes. And right now, our capability is implanting 60 electrodes into the retina. So we got a long way to go to take someone who has no light perception and be able to give them normal vision through one of these Argus II retinal electrode type devices. Still fascinating, amazing nonetheless. And the next generation of these devices, there's a developer of this implant that's working on a device that will have 240 electrodes and also peripheral electrodes. Most of the time, this device, what it does now is it sits in your central retina. So it's right in the macula, because that's where your central vision is. So if you're going to try to give someone vision, you want it to be right in the middle. Well, a developer's looking at trying to do 240 electrodes. So, more than twice as good a vision. Maybe that's how it works. I'm not sure. But also some peripheral electrodes as well to give some peripheral vision, which is great. So really cool stuff. But obviously, I can't even imagine how hard it is to develop something like this, to be able to send a picture like that from a camera to electrodes in the retina and have it. And the other thing with this is, as I mentioned, there's lots of different types of blindness. Well, another type of blindness is due to optic nerve dysfunction. And so the success of these devices requires a normally functioning optic nerve. Unfortunately, a lot of diseases take out your optic nerve. You don't have a normally functioning optic nerve. I saw some today in clinic. Patients with ischemic optic neuropathy. One patient that had giant cell arteritis. Optic nerve shot. Not going to get vision back. We still don't know how to repair optic nerves. That's the final frontier, I think, because then you're talking, okay, well, if can we transplant an eye at that point? I mean, that's what's stopping us is sever the optic nerve. You can't put that back together. I don't know. I say that's what's stopping us. I don't know. There's probably 1,000 things stopping us, but still really cool. That's bionic eyes. That's all I know. That's all I have for you. We cannot do eye transplants yet. We are not there. There was the transplant community. I mean, I think the last new transplant thing I heard of was like a full face transplant. People are doing that now. So who knows? I mean, we do cornea transplants, and what we can do like single layer cornea transplants. You can take like a single layer of your cornea and transplant that into the eye. And so it's just, it's the people that are doing this thing and just bringing us into the future and further into the future is just amazing what they can do. And especially these patients, man. These patients with retinitis pigmentosa who slowly went blind in their youth, in their teens, their 20s, kind of gradually losing their peripheral vision until they had a single island, and then that went away. To be able to like give them something is life. I mean, it's life changing. It's world changing. And so I hope this work continues, and can't wait to see what happens in 10, 20 years. All right, let's take a break. All right, I've got an interesting patient I saw today. This is a first for me. I have never seen this in clinic. I was trudging along, trying to get through Friday, and everything's going okay. And then I had a bump in the orbit, or not the orbit. That's not what the patient. It was like a bump. Eyelid bump. That's usually what it's described as for people. So I was expecting, okay, it's probably like a sty. It's probably could be like a little basal cell. That gets kind of exciting. Maybe a seborrheic keratosis, for lack of a better way to describe it, an age spot. That's how people like to say it. But no, that's not what it was. So this is a young woman who came in with a bump on the outer part of the eye and had to lifted up the eyelid on the outside, and you could see it underneath the eyelid. It's in the same place where sometimes you can have orbital fat that starts to prolapse. So there's orbital fat that's held behind your eye, back there with all the eyelashes that you've lost over the years. No, I'm just kidding. They don't go back there. But you do have fat that fills your orbit, the space behind your eye. As you get older and the tissues relax, that fat can migrate forward, and you can actually see it if you pull. For some people, it's not everybody, but if you ever like pull up on your eyelid, and usually we see it in people probably over the age of like 50, 60. Pull up on the other eye, you can see it kind of like a little fat, like a glob of fat that kind of falls down. You can see it sometimes. It looks yellow. But this was not that. This was a young person. And not only was there like a mass there, kind of coming down from the orbit, the superior temporal aspect of the orbit, but there were a couple of hair follicles coming from it. Interesting. What do you think that is? Now, I've seen things like this come up on TikTok, and the first thing everybody says, oh, that's a teratoma. Teratoma. That's what people know. That's what people like. That's like, for some reason, that sticks out in people's mind when they go through like a human biology or anatomy class or I don't know, maybe it's all people in medicine that just, because a teratoma is such a weird thing, right? It's a tumor. A teratoma is a tumor that contains elements of all the different embryonic tissues. So you get like this tumor that can contain hair, teeth, I don't know, fat, muscle tissue, who knows, just anything. And then, but But that's not the most likely explanation. When you see a tumor of the orbit that is hair-bearing, that's actually not the most common. The most common thing, and what this was, is a dermoid cyst. So big difference. So a teratoma is extraordinarily rare to happen on the eye. And if you do get an ocular or orbital teratoma, it's diagnosable and removable and sometimes fatal. It can be massive. And usually the eye does not develop. The eye is rudimentary. It's never formed properly. I mean, if you're not for the faint of heart, but you can look up Google images of an orbital or eyeball teratoma, and it's not pretty, and so it's a major deal in a newborn, and it's very, very rare. I've never seen that. I've never seen a teratoma in that spot. It's very uncommon. I think they're most common, like kind of in the abdomen, maybe the spine, retroperitoneum. They don't happen around the eye. They can, but it's very rare. But this was a dermoid cyst, which is a congenital choristoma. So a choristoma is a benign tumor that has histologically normal cells, which is what primarily distinguishes it from a cancerous tumor. Histology is totally normal, but they just occur in an abnormal location. So a dermoid cyst can consist of, usually it consists of keratinized epithelium, just like you might have in your skin, and then adnexal structures that you'll find in like dermis in your skin. So like hair follicles, sweat glands, sebaceous glands, and they can slowly get a little bit bigger as you age, which is why this person probably didn't even know they had a dermoid cyst because it was small enough. It never caused any problems. And then all of a sudden they got a little older. It started to get a little bit bigger. Oh, okay, there it is. Or maybe I think probably they'd known it was there for a while, but just kind of finally just getting around to coming in and having me evaluate it. So it's one of the most common orbital tumors in children. It's probably about 50%, 46% of childhood orbital neoplasms. And so it's a pretty common thing to find in kids as far as orbital tumors go. Often, the way children present with this is like I mentioned, a slowly progressive, slowly enlarging, non-tender mass near the lateral eyebrow. And then when it presents in older children or adults, like in this case, it's usually like proptosis. It's pushing the eye in a particular direction, and often that will cause diplopia, double vision. Because you can imagine you have this big tumor that's pushing the eye in a particular direction. And it's very fascinating because I've never seen one of these. I've heard all about them. I've read about them. I know about them. And then there were like two, just like you just take like a very long eyelash, long eyelashes that you normally see in young adults. Young adults have fantastic eyelashes. They're just sticking out of this tumor. It was wild. It was cool to see. I'd never seen that. And this patient's going to do great. Sometimes if you suspect that it's going really deep, like it's causing a lot of proptosis, then you need to get a scan, like a CT scan. And we did end up ordering an orbital CT scan because when my partner, the oculoplastic specialist, takes this out, he's going to want to know exactly how deep it goes into the orbit. So we're getting imaging, and it's going to be removed. And I think it's a relatively small one, at least according to my specialist friend. And we'll take care of it. And patient's going to do great. It's going to be great. Now, these you don't have to remove. This is something that can be, if it's small, if it's asymptomatic, doesn't require treatment. You don't have to remove these dermoid cysts. But if you take it out earlier, it's always easier to take these types of things out earlier when they're smaller than when they start getting really big. But that's the way to treat them surgically. It's probably, I think it's a pretty straightforward thing for orbital surgeons. So more power to those orbital surgeons. That's a scary place to work. There's lots of stuff back there in the orbit. I dare not go there. But you see before and after pictures of surgery for little kids that have or dermoid cysts removed, and you hide the scars, usually just hidden right in the eyebrows. You never know that a surgery was done on the face. So it's really cool. That's the eyelid, the eyebrow is a very convenient place to hide scars. In the eyelid crease, we do a lot of that. We hide a lot of scars there. Forehead wrinkles for older adults. Those of us with wrinkles, all right? I got some of those. I'm developing them. I try not to raise my eyebrows too much because it'll just accentuate them. But that's okay. We all get them. We all get wrinkles. That's our show. That's it. That's our show. That's my show. I'm done. I think I've given you all you need for one day. That's Knock Knock Eye. Thank you all for listening. Give me your comments and your questions. Give me your feedback. Did I say something wrong? Sometimes I make a mistake. Oh, a while back, that reminds me, I got an email from someone who says, when I'm talking about a patient I have with Graves' disease, I mentioned that the thyroid was low and the TSH was high. That would be hypothyroid. I screwed that up. I just didn't say it correctly because Graves' disease, in this case, was hyperthyroid. And so the thyroid hormone was high, TSH was low. That's what the labs were doing. So sometimes I screw things up. All right, please reach out. I'm happy to correct myself. I'm always correcting myself. No one's perfect. But just tell me what you think. Give me your topic suggestions, any eyeball or eyeball related stuff or any medical related stuff, any topics in medicine you'd like me to talk about with you. Happy to. All right, this is your time just as much as it is mine. Go leave a comment on my YouTube channel at Glaucomfleckens. That's for the podcast. So all the episodes you'll see up there. We also have a Patreon if you're interested for the podcast, Knock Knock High. And thank you to my producers, Aaron Corney, Rob Goldman, and Shanti Brick. Editor and engineers, Jason Portizo. Our music is by Omer Benzvi. Thank you all for joining me. We'll see you next time. Human content, Knock Knock High is a human content production. Take care.
Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.